Welcome to the final day of Innovations, and we have a short but dense section of technology and techniques for you this morning. I am Richard Link. I'm a professor of urology and director of the Division of Endourology and Minimally Invasive Surgery at Baylor College of Medicine. You may know that there's a bit of a shakeup going on in the world of minimally invasive surgery that's related to the development and deployment of single-site robotics. And for the first lecture this morning, I'm going to try to give you a little bit of a perspective about what that means, maybe for your practice, maybe for your future practice, a little bit of a trip down memory lane, and try to give you some insights from my own experience with this over the past year and a half or so. Here are my disclosures. So I think as urologists, we all understand that we've been on this journey of technology development in minimally invasive surgery since the early 1990s. But you know, the current state of affairs in this world is a bit of a messy toolbox. If you look at what techniques are being done, you see this huge diversity of techniques: laparoscopy, robotics, single-site laparoscopy, hand assist, open surgery. And we're doing things in all different ways. We're doing them transperitoneal, extraperitoneal, retroperitoneal, et cetera, transvesical. It's a bit of a mess. So how do we put this into perspective to understand what we should be doing, what we will be doing in the future? So here's an example of that. So you may know I'm a little bit of a Twitter aficionado or X aficionado. So this is a poll I put up back in May, and it's a simple clinical case of a patient with end-stage renal disease and a small renal mass who needs a radical nephrectomy. And when you look around about 120 urologists, you see a whole bunch of different approaches to do the same thing. About a third would do this laparoscopically, about 60% would do this robotically. There's still people doing this open, single port. Likewise, about 3/4 of the practitioners would do this case transperitoneal, and a quarter would do it retroperitoneal. And I think the take-home message from this is simply that there is not really a consensus today in what the best approach to do even simple things within our field are. And I kind of feel like urologists are often looking at the sky like dinosaurs, looking at the new techniques coming down the pike and how they might sort of destroy their world, essentially. You know, if you were an open kidney surgeon in the 2000s and you didn't embrace laparoscopy, you're probably out of a job at this point, right? So that was one. And certainly robotics in the mid-2000s was the same. If you were an open prostate surgeon at that time, you really had to adopt robotics to continue to do your practice the way you wanted to. But there are some examples where that wasn't the case. So less or single-site laparoscopy in the 2010s, although Dr. May and I are very big aficionados of this, it really never panned out, never caught on. So what about single-site robotics today? Is that an asteroid coming down to destroy our world, or is it another flash in the pan? Well, hopefully today we'll get to the bottom of that. I mean, we don't want to be lemmings, right? Every time a new technology comes down the pike, we don't want to be that person jumping into the water. We have to have some reason to do that. So let's think a little bit about invasiveness in urologic surgery. Obviously, open is our most invasive approach. I would then categorize hand assist as the next most invasive approach. Then we move into the multi-port laparoscopic procedures like robotics and standard laparoscopy. Less is kind of a little bit less invasive. And then I would say that the SP, as I'll describe a little bit later, is probably the least invasive approach that we have to do these tasks. So here's an example of some cases where there would be controversy. So here's a case of an 11-centimeter tumor. How would you do that radical nephrectomy? Would you do that open? Would you do it multi-port lap, multi-port robotic? How would you do that? Similarly, a small anterior partial. Is that a robotic case? Is it single port? Is it multi-port? How about a posterior lesion? Would you do that case retroperitoneoscopically or trans? I think you could ask 100 urologists around the country and you'd get a whole bunch of different answers to these questions. Similarly, radical prostatectomy. Are you going to do that case transperitoneal, extraperitoneal? Are you going to do Retzius sparing? There's a lot of confusion about what the best techniques are. Same thing with simple prostatectomy, even pyeloplasty. You know, we made this transition from laparoscopy to robotics in the 2000s because robotics was faster, it was more precise, it was easier to teach, a lot more ergonomic. So that was a fairly straightforward transition. But we've kind of gotten a little stagnated over the last decade. And just as an example of that, this is kind of the impression I have of our skill sets over the past, 20 years or so. And we had this growth of skills in the early 2000s, but over the last 5 to 7 years, we're steadily losing our laparoscopic skills, and we're losing our open skills, of course, and everything has become multi-port robotic. So how do we go forward from that? Well, one approach was to go to less, right? Less is single-site robotics, but less is less versatile. It's definitely technically harder, especially for reconstructive tasks, and it really has very modest morbidity benefits for the patient. So the next step in that evolution was to move to this single-site robotic platform, and I would argue that the SP is certainly more versatile in many ways than multi-port robotics. Is it technically harder? Perhaps, depending on how you use it. But it definitely has very significant morbidity benefits versus transperitoneal multi-port robotic procedures. And I think one of the things about the SP is it's energized our field in the sense that there's just a lot more excitement about the things that we've been doing and pushing the envelope that was missing a few years ago, as I said, in that period of stagnation. So should you care? Is this just another tool to throw into that messy toolbox, or is this that asteroid that's going to come down and wipe out your multi-port robotics practice? Well, we're talking about the Da Vinci SP, and for those, I'm sure everyone knows what this is, but it's a single-site robotic platform which has arms that ramify out of a single entry point. It has a very small footprint, and just two key concepts. The first is that it has basically a softball-sized working envelope, and you move that working envelope around the abdomen. The other thing is its small footprint is very valuable. So for example, you can simply swing this device around that focal point to access different parts of the abdomen, different parts of the retroperitoneum. It's very versatile. So why would we use that? Let's use an example for nephroureterectomy. You can simply orient the device this way to look at the kidney in the retroperitoneum, and then just swing it around to look at the pelvis through the same incision in the pelvis. And this is a very versatile and easy way to handle something where you're dealing with upper and lower tract at the same time. A couple things about the SP for advantages. It works through a small incision, about 2.7 centimeters is the smallest. It's got robotic dexterity, so it's not like trying to sew with less. It's very advantageous for procedures outside the peritoneal cavity. Very versatile for multi-quadrant surgery, extremely good for small spaces, and a lot easier to teach for reconstruction than lap or less when you're dealing with residents. It has a few disadvantages as well. Its cost and scarcity, it's not available everywhere. There certainly is a learning curve, as there is in any technology. You have lower grip strength of the instruments, and there's a standoff distance, so there are tricks that we use to give us that standoff distance to work effectively. It definitely marginalizes the bedside assistant, so it's something you have to get used to. And the instrument variety is less than with multi-port robotics. And I think probably the most critical one is it does have some challenges with large specimens. So when I think about the history here of the last 18, 19 years of this field, I think about when I finished fellowship. So in 2005, I finished my fellowship, and basically when I thought about minimally invasive surgery, I was doing multi-port laparoscopy, except for prostates, where we were doing robots, and then open was maximal. And over the next 15 plus years, it basically looked pretty similar. We had multi-port robotics or less for minimally invasive options, and our maximally invasive option was open. But I will tell you that after about a year and a half of doing SP cases, this is kind of how things look to me today. The SP is basically my minimally invasive option, and there are some less cases still. But I look at the multi-port robotic as almost a maximally invasive option. In fact, that's what the operating room looks at. When I post a case on the XI, they think, okay, there's something going on with this case. It's a complicated case, it's a difficult case, a difficult patient, something like that. And that's a pretty big change of mindset over a relatively short period of time. Why? Well, it's easy to think that this is a cosmetic argument, right? This is an example of a less case of a donor that we did. But I would argue with you that that's not really the case. Now, you can certainly use the SP to do cosmetically advantageous procedures. So here's an example of a transperitoneal partial nephrectomy for an endophytic tumor done essentially through that. Okay, so less than a less incision. So you can do that. And there are certainly some patients for whom that cosmetic advantage is a significant one. But I think we would all agree that's not the majority of our patients who need retroperitoneal surgery. So the real question here is this cosmetic concern argument, I kind of think is a paper tiger in this world. I mean, patients get referred to me for laparoscopy. Referring doctors and patients know what that is, and they know what robotics is. So I'll get patients referred for that. We've been doing, Dr. Mayer and I have been doing less for 10, 12 years. Nobody ever sends us patients for single site surgery. They just don't know about that. The patients don't know, the physicians don't know. So it's not really driving this referral pattern. This is what's driving the advantages of the SP, not the cosmetics. We started out in urology doing all of our surgery in an extraperitoneal manner, right? We did extraperitoneal kidney surgery, we did extraperitoneal prostate surgery, and then when laparoscopy came around in the 1990s and early 2000s, we moved everything into the peritoneal cavity. And so we started doing all our surgeries transperitoneal. And the robot, the SP robot, what it's doing is it's driving us out of the peritoneal cavity back to where we started so that we can harvest the advantages for our patients of doing these procedures in an extraperitoneal manner. So just an example of what we do with this robot. So certainly you can go through the umbilicus for transperitoneal surgery. We can do flank entries for this in the retroperitoneum. One of the most valuable is to do the low anterior approaches. So we've gone to doing most of our kidney surgery using a low anterior approach where we're purely extraperitoneal. You can also do suprapubic approaches. And then transvesical surgery is really facilitated by the SP. So it's these separate new approaches to approach the same organs and the same pathology that really make this interesting and exciting. So I'm going to do two case studies for you. I'm going to talk a little bit about partial nephrectomy and then a little bit about simple prostatectomy. So previously, I was basically a transperitoneal curmudgeon. I would have told you that almost anything can be done transperitoneal. We don't need to do retroperitoneal surgery. I probably did 15% retroperitoneal surgery at most. Over the past 6 months, after doing SP for about 8 months or so, I'm basically doing 80% of these cases retroperitoneally. So, and all of those with the SP. I still do some transperitoneal partial nephrectomies, usually with the XI. So if I'm going to do a transperitoneal procedure with for a partial, it's usually going to be with the XI because there's some reason I'm doing that. I'll show you a few examples of that. Occasionally we'll have a patient where there's a cosmesis driving factor here, and then we might use the SP. So here's an example of a case, and I'm not going to show you a lot of videos today, but here's an example of a case that I would have done retroperitonoscopically 2 years ago. Okay, posterior tumor, hilum. It's a great, posterior approach. Not an easy case to do transperitoneally, and we would have done that using multiport. In this example, we just do this through a single McBurney's point incision with the SP. But let's jump ahead to this case. This is that case I showed you earlier. It's an anterior tumor, somewhat endophytic. This is not a case I would have done retroperitonoscopically. I think that's quite difficult to access through a flank access retroperitoneal multiport approach, but it's very straightforward to access that using the SP with the same incision. So just as an example, this is a little bit sped up, but we've made our incision, we docked the robot, and we're going in. And the time it took us to go from entry to hilar isolation was 8 minutes. And we were able to clamp at 22 minutes, and the whole case took less than 60 minutes. So this is not something that you can realistically do with a transperitoneal multiport approach. And I would say that our partial nephrectomy procedures today are routinely taking 90 minutes. So that's a difference between doing 2 versus 3 robotic cases a day. It's a difference between doing 2 robotic cases and a few ureteroscopies. It's actually quite advantageous from an efficiency standpoint. And this is just going through the hilar dissection, which is actually really very easy to do using the SARE approach. That's the lumbar vein, and we'll be coming right up to the hilum right here. Jump ahead here. There's your hilum. It's very nice. You can get to the renal vein very easily this way as well. Here. Okay, a couple other things about the SP. There are some advantages from the anesthesia standpoint. Much less extreme positioning, easier from the standpoint of shorter procedures and extraperitoneal access, so less likely to have intra-abdominal injuries. and less pain, of course, from the extraperitoneal approach. Here's an example of a multi-port retro case. Patient's in flank, bed is flexed. This is a long process of annoying positioning. Patient is just supine for the SP approach, so it's very nice. If you get into trouble here, the anesthesiologist is much happier because the patient's not on their side and flank. Here's a 485-pound patient. This would not have been a fun patient to put into a full flank position and crack the bed. You simply place them supine, put a little bump. It's very straightforward for Sarah access. I still think there's a role for the XI. As I said, the SP is not a great device for large specimens. So these are some examples of partials that we did. And again, this is a good situation to use the XI. You need the Superman strength. Big tumors, 8-centimeter tumor, 11-centimeter tumor, or perhaps a tumor where we want to approach it from the perspective of the renal vein. So there's some advantages to going transperitoneal in that case. So the SP lives within an infrastructure that includes the XI. It's not replacing the XI. The nice thing about these patients is that they almost all go home on post-op day 1, many on the morning of post-op day 1, which is really not our experience with transperitoneal multi-port robotic partials. They have a lot less pain than the transperitoneal patients, and they're really much more comfortable after the surgery. So here's another example of simple prostatectomy. Prior to SP, I was doing 100% of these transperitoneally. They have a great outcome. They do wonderful in the medium and long term, but they have a bit of a rough time in the initial post-op period, just like any transperitoneal procedure would do. Over the past 8 months, we've transitioned to doing 100% of them transvesically with the SP up to 350 grams, no CBI, no drains, discharge either from PACU or at the morning of post-op day 1 if it's an elderly patient from out of town. We leave the catheter in for these patients for 3 days. This is, again, an example of a 320-gram prostate done transvesically. You can see we're entering here. There's the balloon of the catheter. I'll show you a little better video in a second. And this is the reconstruction at the end. So here's just a fun one. So these are equally sped up. And this is how we would do a trans-abdominal simple prostatectomy. And, you know, the usual thing, you got to open the bladder and put in retraction sutures. Yes, you can do them without retraction sutures, but this is the way that many of us do a transperitoneal simple prostatectomy. There's just a lot of stuff to do. You know, you got your ports in, you've got to set everything up, you're putting in sutures, you're cutting. Usually the resident is doing this, so it can take a little while. And I'm on my laptop, you know, searching the internet or trying to write papers or things like that. We're almost done. Just keep at it. Okay, now we got to get those needles out of there. We don't want them poking anything. Okay, the needles are out, and we're good. All right, so where are we? Oops, I don't want to do that. Let's see if I can get this to go. Oops. Can we go back a slide? Okay, well, the bottom line is this one, look how fast this is. There, we're done. Okay, so it's a really quick process. So instead of 30 minutes, it takes 1 minute to do that. Okay, so let's just think a little bit about the mindset. So when I started doing SP, this is how I looked at its role. I thought about it basically for a very small subset of the cases I would do, mostly ureteral reconstructions, and the things in the interface here were mostly cosmetic driven. Everything else was XI. So I was thinking about it from the point of view of, can I do this with the SP? Today, it's the opposite. Basically, almost all my kidney and ureter and prostate procedures are being done extraperitoneally with the SP. Certainly, there are some severe cases that need the XI, either patient factors or pathology factors, or procedures that have to be done transperitoneally without a lot of cosmesis-driven factors here. And the stuff in the interface are things that could be done either way. And what I'm really thinking is now, do I need the XI to do this efficiently or safely? So it's a real big 180-degree flip. And if you look at where I was in July of 22, I was doing about 75% of my cases with the XI, and a year later, I'm doing about 80% with the SP. And that just reflects that mindset. And really, that transition occurred when I got out of the peritoneal cavity. Here's an example. This is a patient with a dead kidney from a distal stone that was missed. And previously, I would have simply done this as a multi-port transperitoneal nephroureterectomy, port hopped, et cetera. Today, that's really just a straightforward single incision retroperitoneoscopic procedure with the SP. So you've saved a lot of morbidity with that approach. You know, the SP is kind of at this point in its lifestyle, you know, the multiport is out here and the SP is down here, and we're trying to get across this gap. And again, you don't want to be a lemming. And whenever we adopt new technology, it's really a tension between availability and how much training we need to do, patient benefits, and the versatility to the patient. So again, that's important. And I would just jump ahead here and say, if you're looking at starting with the SP, understand that there's some tension between a new platform and a technique that you may already be comfortable with. And there's this life cycle that happens in a lot of people where they'll get very excited about it, become disillusioned after a while, and then hopefully move on to expansion and adoption. And some people then quit at that point. And I would argue that just keep in mind, the SP is not an XI. So the sooner you stop trying to do your surgeries XI style with the SP, the quicker you're going to avoid these landmines. Again, if you're looking at these things, radical prostate, partial nephrectomy, simple prostate, try to get out of the peritoneal cavity as quickly as possible so that you get the benefits, so that the view at the top is worth the climb. And the reality is this robot is not hard to drive. It really doesn't take that many cases to master sewing with it. There are just some more variables, and there's a little bit of more mental stress and strategy involved in using this. And the challenges are really procedure specific. So I would encourage you to get out of the peritoneal cavity and into the procedures that you want to do as quickly as possible so you can master those challenges. And again, we're seeing this progress in this field. We're seeing new instruments developed for this device. We're going to see costs get down a little bit. Availability is going to go up. So this is, I think, the future of where we're going. So in conclusion, you know, the landscape of urologic MIS is still a little confusing and convoluted, but it's really shifted towards robotic approaches over the past decade. I do think the SP has really energized our field and is making this much more fun and exciting than it was 5, 6 years ago. Cosmesis is not the driver behind this process. Although it is a benefit, it's not the driver. And again, it's that regionalization of surgery that is driving the value with SP, and it's why I think you should think about it if you do robotics in your practice. Thank you.